This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
First of all, my name is Brian Feeley. I'm one of the shoulder surgeons at UCSF. I've been here for about 6 years now. I did my training at UCLA and then was in New York for a specialty year in shoulder surgery. So there are really three things I love more than anything else: my family, going surfing, and shoulder surgery. Anytime I have the opportunity to talk about any of them for an extended period of time is a little bit dangerous. I know this room isn't used again until tomorrow morning's grand round, so I expect about 12 hours worth of talks. So I think this is kind of an interesting idea. When I was asked, well, what's new in shoulder surgery? Well, I want to focus on what's new in medicine. And this is the third year I've given mini med school. And one of the things that's always impressed upon me is that you guys know a lot more than what I would say people would know 10, 15 years ago. There's so much more access to information that most people know a lot about shoulders, a lot about knees, and a lot about their own conditions. So I wanted to start with what's new in medicine. What's changed since I went to med school about 10, 15 years ago? And first is that we focus on more problem-based learning for medical school. And what that means is that we can really, instead of going over each organ system and saying, this is everything that's going wrong, we go through case by case, identify what the most likely problems are, and then come up to solutions and treatment algorithms based on that. So I thought one thing we would try to do differently is today do more of a case-based rather than a laundry list of shoulder problems, and get you guys to be interactive and think about this as if you were shoulder surgeons. Also, this was really boring. I mean, this is how I spent most of medical school. I fell asleep in pretty much every class, and I survived. But I find that the problem-based learning is much more interactive, partially because there's always fear you might get called on. And this is much more like being a physician, is we don't get to just sit and listen to patients talk in a group of 50, 60, 70 people. We have to interact one-on-one and come up with what the patient's problems are and come up with solutions for them. There's also been a much bigger increase in actually using evidence-based medicine. And what that means is when I was a medical student, what I listened to is somebody who is significantly older than me say, I think this is a rotator cuff tear because this is how I see them, and we're going to treat it this way because that's what I like to do. There is much more of a shift now towards looking at what the evidence is to give everybody the best possible care. So in order to do that in a lecture, what I thought I would try to do is focus on some of the more recent literature that's come out in shoulder surgery and try to teach that to you all so you can make informed decisions about your shoulders or your friend's shoulders. So we're going to do this like medical school. You do need some basics. So we're going to start off with anatomy, go over a differential diagnosis, which is essentially what can go wrong in the shoulder, go over how we take a history for shoulder in a focused period of time, and do a physical exam. And then we're going to go into more problem-based learning and talk about common shoulder problems and focus on really what's new and exciting in shoulder surgery. And because I do a lot of shoulder research, I am going to highlight some of the research that we do at UCSF because it's fun and I get to be a little bit nerdy. So by the end of tonight, or at least 2 a.m. tomorrow, I want you to be able to understand how the shoulder functions in general terms, be able to diagnose and manage common shoulder problems. So your friends that you see walking around and they're raising their arm up like this, you should be able to go up to them tomorrow and go, you've got frozen shoulder. You need to get in and get treatment. Don't worry, you don't need surgery. I know everything about it. And I want you to know what the state-of-the-art evidence is, not what people knew 15, 20 years ago, but really what's coming out of laboratories and out of clinical research in the last 5 to 10 years. And by the end of this, you should all want to be a shoulder surgeon because really a shoulder is a pretty awesome joint. So when you think about the shoulder, it's got amazing capabilities. First of all, there's two, the wonders of orthopedic surgery. There's two of almost everything. So if you're not sure what's normal, just test the other side. When if you're not sure on a patient, then you've got two of your own usually. So you've got 4 things that you can test and hopefully come up with what's normal and what's abnormal. For a joint, it has the greatest range of motion in the body, not just from the glenohumeral joint, the ball and socket. If you move your arm backwards, you've got your scapula moving, you've got your AC joint moving. There's a wide range of range of motion that your shoulder can do that no other joint can do. And we'll go over a little bit about why that's important and how your shoulder does that. Because it has so much range of motion, it has very little inherent stability. This stability is mostly based on the muscles. You'll see in contrast, if you think about a hip is a true ball and socket. The ball is well inside the socket. When people tell me they dislocate their hip, I just kind of smile and say, no, you don't. Because if your hip comes out, it sticks way out and you can't walk. That little popping isn't a big deal. A shoulder, you literally can slip and fall the wrong way and dislocate your shoulder. In order to stabilize a shoulder, you need both dynamic stabilizers, which are the muscles around the shoulder, as well as static stabilizers, the inherent stability by the bony and cartilaginous structures. So I want you guys to all use one hand. We're going to go over some of the surface anatomy. And we're going to start in the middle of our shoulder joint. So if you feel the little bump, if you feel right in the middle of your neck, and then move over, the first bump you have there is your sternoclavicular joint. This is a very rarely injured joint, but it is important. Some baseball pitchers can sublux this when they throw, and they'll get a painful bump there. The reality is almost always we don't want to do anything to a sternoclavicular joint unless it's dislocated posteriorly, which is exceedingly rare because lots of important blood vessels are right behind it. In general, orthopedic surgeons like to stay away from things that bleed a lot. So if you walk along this bone that you feel, that's your clavicle or collarbone. And the next bump you're going to get to is your AC joint or your acromioclavicular joint. Your acromion is a projection of your scapula that comes forward. So you can feel that as kind of a ridge on the top of your shoulder. And that's going to connect to the clavicle at your AC joint. This is not a normal joint like a hip joint or shoulder joint. This is a joint that's closer to how your discs are in your back. It actually has a little disc in between these two bones. As we get older, 100% of you will have degeneration in this joint. It's normal. Accept it and be happy that your joint clicks when you do push-ups because that means, hey, you're doing push-ups. That's not too bad. If you feel the outside, this bulk, so this gentleman here is saying, God, I can't even get my hand around it. That's your deltoid. Okay, deep to that projection you feel is a hard bone in the front or in the side is your greater tuberosity. That's important because that's where all your rotator cuff attaches. All right, now if you take your hand and move a little bit more to the front and find the most sensitive spot right on the front of your shoulder, that's going to be the long head of your biceps. And we'll go over that because that's something that's very poorly designed in ourselves, but tends to get injured and therefore gets injured a lot. So we're going to start from the outside and go in. So we'll skip skin and we'll go to your deltoid. Your deltoid is a powerful muscle. It's one of the 3 most powerful muscles in your shoulder. I think you've got your deltoid muscle, which is going to allow you to raise your arm up. It does not do too much to control rotation. That's going to be mostly your rotator cuff. You have your pec muscle in the front, which is going to bring your shoulder forward, and your lat muscle in the back that's going to bring it down. So if you guys have gone to the gym, you know how to work all these muscles. These are important large stabilizers of your shoulder. They're not too important for subtle motions of your shoulder, but they're important for initiating and controlling motion. Now I just want to back up a little bit and talk about how muscles work. This is what most of my research is in, so I'm going to keep this very non-nerdy for now. When you think about how muscle works, muscle is a contractile organ that attaches from bone to bone by the use of a tendon. So when we talk about a rotator cuff today, we're talking about the muscle of the rotator cuff turning into a tendon and attaching to the top of the shoulder or the front of the shoulder. If you're talking about things like an ACL, an anterior cruciate ligament in the knee, ligaments can connect bone to bone. I realize that through most of medical school, I don't think somebody ever actually taught me that. It was just one of those things you inherently knew. And I think I was halfway through medical school, so I realized, gosh, if somebody had just said that, I think I would know it. So speaking of important tendons in our body, my favorite tendon in the world, your rotator cuff. It's not called the rotary cuff, so one pearl for today. If your friends call it a rotary cuff, just say, no, it's a rotator cuff. Orthopedics in general, however, is very simple. If you're not sure, we name things for how they function. This is a cuff of 4 muscles that goes around the shoulder and serves to initiate movement and rotate your arm in space. So, rotator cuff. There are 4 muscles. The most important one is your supraspinatus. This is the one on the top of your shoulder. This is going to initiate movement and is the most common one that's torn with rotator cuffs. Your infraspinatus and teres minor are in the back of your shoulder. They're going to allow you to bring your arm back. Remember, too, though, you've got all your big back muscles that are going to allow you to do this, too. So you can even have isolated tears in these and be okay. Your subscapularis is the most often overlooked rotator cuff. It sits on the front of your scapula, so still behind where your ribs are, but comes and attaches to the front of the shoulder. This is going to help bring your arm forward and in, and can be torn. We'll get to it later, but it's more commonly torn than we previously thought. The 3 most important functions of your rotator cuff: it gives you motion, and like we said, it initiates and controls motion. It is going to give you stability. It's the most important stabilizer to the shoulder. So how does your shoulder not dislocate? Your rotator cuff is always firing and keeping your shoulder well engaged within the joints. And it works exactly opposite the deltoid. The sum total of these 4 rotator cuff muscles is about as strong as your deltoid. And that keeps your shoulder well centered in the joint when you move it up and down. Now, the long head of the biceps we talked a little bit about. Now, there's a lot of things in your bodies that are really, really, really well designed. You know, our ears face sideways so we can hear other things. I'm a predator, so I look forward. But things that aren't well designed, I eat where I breathe, that's a horrible idea, right? I mean, you should never have the need to choke while you're talking. My younger daughter talks constantly. I'm pretty sure we're going to have to give her the Heimlich maneuver at least 4 or 5 times just because she enjoys talking. If we were better designed, I wouldn't have to worry about her. In the shoulder, it is a beautifully designed system except for the long head of your biceps. Your biceps is this muscle here. At least 5 or 6 guys just flexed involuntarily when I said biceps. It was awesome. There's 2 heads, hence biceps. If you feel the bump on the front of your shoulder, that's your coracoid. The short head, which isn't pictured here, comes down there. It's really well designed. Like every other tendon in the body except for one, it goes straight. Your long head is just a bad idea. It comes through the middle of the joint, goes through, makes a right angle turn, and runs down the front of the shoulder. So if you spend a lot of time leaning forward, typing, not activating your shoulder, and then go to the gym, do a lot of curls, or God forbid, do CrossFits, you're at a high risk of injuring this. Now, we don't exactly know the role of the long head of the biceps. Some people say it's totally vestigial. Some people say it's an important stabilizer, but it is the most common cause of anterior shoulder pain. If there was a test at the end of this, I would write that down. The most common cause of anterior shoulder pain. Very likely to injure it in CrossFit for reasons I'm not entirely sure. So why do we have that? Well, if we walked on all 4s, it is a good stabilizer if we're walking on all 4s. So if you want to use your long head of your biceps better, walk out on all 4s, but it's awkward, okay? So moving into the static stabilizers, your shoulder is somewhat of a ball and socket joint, but it is not a normal ball and socket joint. You have your humeral head, which is the ball, and the glenoid, which is the socket, and there's this little labrum that goes all the way around that deepens the socket. And I think the best way to think about the shoulder joint, it's like a golf ball on a tee. There is very little inherent stability. I don't play golf because this is a very complicated and frustrating sport that you have to blame yourself when things don't go well. I like to blame bad ocean conditions, sharks, things like that. But if you look at the golf ball on the tee, little tee, big ball. When you look at the shoulder joint, you have a big ball on a relatively flat, small tee. So your rotator cuff and the muscles of your shoulder are very important to give you that stability. However, because you have such a flat area, it allows you to rotate all the way back and all the way forward without any problem. Now the labrum, this is looking straight on at the shoulder. This is, imagine if you took the humeral head off and you were looking straight down the shoulder. Your labrum is a thickening that deepens the glenoid about 50%, but essentially goes from a tiny, tiny bit not entirely flat to a little bit more. So really when you see the labrum, you look at it and go, gosh, really, that's it? That gives us stability? It really doesn't do too much, but it does serve a couple functions. It does deepen the shoulder a little bit. It serves as an anchor to the capsule, where it has these natural thickenings which conveniently hold our shoulder in, and it also is where the biceps attaches. So what does this look like in real life? So when we do shoulder arthroscopy, it's arthroscopy with an A, not orthoscopy. Orthoscopy would mean I put it into the bone. I try not to do that because that usually hurts a lot more. This is what your shoulder looks like. So this is your biceps tendon here. Okay, so there's no blood in this, so I faint at the sight of blood, so I'll be the first one down. This is your glenoid cartilage. This is the socket. This is the labrum in the front here, and you can see it's not that impressive. That whole thing there is supposed to deepen your shoulder 50%. It's not very impressive, but we can follow that all the way down. This is your humeral head on the side, and then we can look at the back of the glenoid and come all the way back up the back, and we're looking for little tears along that labrum attachment. The next thing we can look at is the undersurface of the rotator cuff. So this is your subscapularis muscle in the front, or tendon in the front. The muscle is over to the left, and we can see it comes down and attaches right next to the biceps tendon. That's me pointing. And then we can look down at the biceps. I'm getting seasick. It must have been a resident doing this one. And then we can look at the rotator cuff attachment. And this is the undersurface of the rotator cuff. And you can see nice cartilage coming over, and then your rotator cuff attaching right here. Now this gives most of the view, but the rest of the view we want is what the rotator cuff looks like from the top on the other side. And this is a demonstration of what the rotator cuff looks like on the other side. So now we're on top of the rotator cuff looking down. This is after somebody's had a lot of inflammation around the rotator cuff cleared up. But it really is a smooth cuff of tissue that goes all the way around the humeral head. So we're not going to get too much into the biomechanics of the shoulder, but I always thought that the biomechanics of the shoulder were pretty straightforward and simple. If you just remember that the rotator cuff is going to fundamentally pull the shoulder in, or pull the ball into the socket and pull down and go opposite what your deltoid does, that's what allows you to center your arm and control your arm in space. Now, why is that important? We call that a force couple. So you want all forces in your body to be relatively balanced throughout any motion. It's just like if you land and you don't fire your quads and hamstrings appropriately, you're at higher risk for an ACL tear. If you lose your force couple, if you get a big rotator cuff tear, what can happen is instead of your shoulder sitting right in the socket down here, your shoulder is going to ride pretty high and rub against your acromion. So this is called a loss of a force couple, or when you get a larger rotator cuff tear, you end up with a shoulder that just doesn't function. You can imagine if you have a big rotator cuff tear like this and you try to elevate your arm, there's no way that you can keep this ball down in the socket, and instead of raising your arm up like this, you raise your arm up like this, and you cannot control your rotation. So the next step of medical school, the first phase 1 of medical school was always anatomy. Phase 2 is much more interesting, and what can go wrong in the shoulder. And there's a lot of things that can go wrong in the shoulder. It was really sad. I had one of our first year med students, I used this picture and they asked who House was. And I was like, geez. And I had just taken out the picture of ER, which made me realize if I put that in or Quincy, God forbid I put a picture of Quincy in there, they would have had no clue. So when we think about a differential diagnosis, we want to think of everything that can go wrong. But we want to do this in an educated way. And that what separates, I think, good physicians from great physicians are ones that can use the available evidence and what they can pick up on a history and physical exam to make an educated decision about what a patient has, whether that's in the shoulder, in the knee, in the heart, in the lungs. This is one of the fundamentals of learning how to be a good physician. So there's a lot of things that can go wrong in the shoulder. Now, thankfully, 1, 2, 3, 4. Not nearly as much as when there is in the abdomen, or the number of infectious diseases that can kill you. So this is a relatively small list. So the most common thing that people are seen in the United States for is a rotator cuff tear. 45% of office visits for orthopedic surgeons or primary care doctors are for rotator cuff problems. The second most common is for shoulder arthritis. The third most common is for frozen shoulder, which we get to. How many of you have heard of frozen shoulder? How many of you have had frozen shoulder? Yeah, so if you've had it, you never forgot it. Good job, good range of motion. That's awesome. Biceps problems account for about 15%. Dislocations are relatively uncommon. Fractures are relatively uncommon. Believe it or not, some people come in with a bruise. It's the happiest patient of the day when I can tell them, you know what, you don't need surgery. You just bruised, you fell down. I have to teach the residents it's okay to tell the patient they don't need surgery, because usually they have the really sad face, like, oh, you don't need surgery. Because that's the happiest day for them. The other thing is cervical spine problems. Things that start in the neck will often refer to the shoulder and go all the way down. So we always have to think, are there other things that could be causing the pain? Now, you might notice that adds up to more than 100%. You might be thinking, well, gosh, now I know why he did ortho. Yeah, actually, I didn't. So the reason is that some of these things go hand in hand. Sometimes I can have a biceps problem with a rotator cuff tear. Sometimes I can have a dislocation, and if I'm older, I'm at more risk for a rotator cuff tear. So there is a fair amount of overlap. When you approach shoulder problems, you want to think of the main things that'll go wrong. So we're going to focus kind of on these top things here, because I want this to be as high yield as possible. So rotator cuff tears, the most common complaints are pain at night and pain with overhead activity, and fundamentally weakness that wasn't there before. And that makes sense. A rotator cuff, if you've got a tear in it, you're going to lose the motor to your shoulder. You're not going to be able to elevate it. When you have shoulder arthritis, you have pain all the time. That's different from pain from a rotator cuff. Rotator cuff pain only hurts when you're trying to use your arm, or for reasons we are not entirely sure, at night. Shoulder arthritis, the arthritis is always there. It always hurts, though patients will describe a toothache. And frozen shoulder is, I come into clinic on a scale of 1 to 10, my pain is a 27, and I cannot get my jacket off for the life of me. And they will say their number one complaint is loss of motion. So to get to a diagnosis, you want a good history, complete physical exam. Radiographs, and especially MRI, are bonus. You should not need them to make a diagnosis. You shouldn't be asking to get an MRI. You should be asking your doctor to make a diagnosis on your history and physical. Okay, so the key questions to ask: was there an acute injury? You were feeling great, and then something really horrible happens? And that's important, especially when differentiating frozen shoulder. Are you losing strength? Again, very important for rotator cuffs. And are you losing range of motion, which are the hallmark signs of arthritis and frozen shoulder? So I usually ask these 3 questions. I try not to ask too many other questions, because I want to spend my time doing a diagnosis and then chatting with the patients, because patients are awesome. They're really fun. Now, if I spend 30 minutes asking them about the nuances of their injury, doesn't help with diagnosis, and it gets me away from trying to come up with a good treatment plan that both me and the patient can agree on. The next step is physical exam, and this is a 4-step process for the shoulder. I want to look at the patient, I want to press where it hurts, I want to check their motion, and I want to test especially for their rotator cuff. So first and foremost, you have to get patients to remove their shirt. A little bit awkward, but it's important to look at all structures. Now, this is a nice example. So this is somebody who, on this side, deltoid looks nice and normal, was complaining a lot about he couldn't raise his arm up after a football game. He has no deltoid over here. So this is somebody who got hit really hard, subluxed his shoulder, got an axillary nerve injury. If I hadn't taken his shirt off, I would have had no idea that that's what was going on. Now, you always have to, it's a little bit awkward. Don't let your patients take off too much clothing. And once a year, I walk in and patients have taken off everything. I go, whoa, whoa. So the shoulder exam, but thank you. So the second thing is palpation, and this is pretty easy, especially with an acute injury. You want to press where it hurts. If patients say, look, it hurts right here, I fell down, and you can press right on the AC joint, and they say, oh my goodness, that's where it hurts. You say, great, you've got an AC separation. Let's look at the x-rays and figure out how severe this is. So in general, if you're tender on the clavicle and you fell down, it's a clavicle fracture. We'll confirm it with x-rays. AC joint. So you asked if you're clicking. If you're clicking and you've got tenderness right on the AC joint, right on that bump laterally right here, you probably have a little bit of AC joint arthritis. It usually disappears with not doing so many push-ups or bench pressing and getting your shoulder blades back. If you have tenderness right down in your trapezius or your neck, it's most likely a muscle strain. I tell patients all the time, look, if your muscles are tender to palpation, that's great. That's something we can get better with physical therapy. Like we talked about, the front of the shoulder is important for biceps pathology. And patients that are tender, kind of in the line of the joint in the back, tends to be a common place for people with arthritis to be tender, although that's not too specific. So next I want to look at range of motion, and this is a great place to torture your patients. So instead of torturing the patients, I will ask them, well, what can you do with your shoulder? If I grab their shoulder and you work them up, you said you had frozen shoulder, right? If I took your arm when you were at your worst and raised you up like this, you'd be sad. So I ask the patients, well, show me what you can do. If they say, this is as far as I can do, this is as good as I've been for the last 4 years, there is no way me trying to yank the arm up like this in an uncontrolled fashion is going to be helpful. So I always ask them, what can you do? If they can't bring their arm up, but they have good passive range of motion, I can get them up. I'm worried about a rotator cuff tear. If their active and passive range of motion is bad, then I'm thinking frozen shoulder, shoulder arthritis, things that are physically blocking them from bringing their arm up, and I can't do it either. After that, the exam's not very helpful for those subset of patients because they're usually in so much pain that you don't get a very specific exam. For most of the rest of the people, we go on to a rotator cuff testing. And we test that in 2 different types. We're going to test for inflammation above the rotator cuff, which we call impingement. And we're going to test the actual muscle strength and look for people who have rotator cuff tears. So this is where your rotator cuff should be. And you can see this is torn and no longer attached. Okay, so impingement tests, there's 2 tests, and the nice thing is they recently looked and saw how specific is this, how good these tests are when you go to the doctor. And this is important. You want to know, is a blood pressure test accurate to telling you if you have hypertension? We assume it is, but it's probably not 100%. In orthopedics, most of our physical exam tests, a good test is about 70 to 90% sensitive and usually not as specific because a lot of them are provocative and can hurt for a variety of pathologies. But it's important to know when your doctor is giving you a test, you want to know how accurate that test is. So a Hawkins test, which this fine young gentleman's demonstrating, you forcefully internally rotate, so think about it like a hawk. This is the embarrassing part about being on video, is this goes on forever. But you take a patient and you forcefully turn them in like this. If they say, oh my goodness, that's the pain I have, it's right here, it radiates down here, I think they have inflammation around their rotator cuff. Neer's test, named after the most famous shoulder surgeon of all time, Charles Neer, is very similar. You're trying to pinch the inflamed tissue above the rotator cuff so you bring the patient all the way up. And they tend to say, yep, that's my pain when you get them all the way up. A little bit of a sidebar, if you're publishing a paper and you're a little bit chubby, take your pager off so you don't know which of the 2 authors you are. So we made a lot of fun of him at the last meeting. We're like, really, you should have had this guy. This guy's in much better shape. But I think he lost the bet, so he had to take his shirt off. So testing for specific shoulder muscles. The first test we do is a Job's test. This tests your supraspinatus. If you think about it, your supraspinatus sits on the top of your shoulder. We're going to push down and ask the patients to resist against me. If they say that hurts, but they aren't actually weak, that suggests they may have a partial tear, inflammation around the rotator cuff, but probably not a full thickness tear. If you push them all the way down and they cannot resist against you, be concerned that they have a significant full thickness tear. Again, this is a not very sensitive test, but it's pretty specific if they're weak. There's very few reasons that you can't keep your arm up like this. So it's a good test when positive, not a great test when you're negative. Infraspinatus and your teres, the rotator cuff muscles in the back, you're going to have them keep their arms like this and push out against them. So I'm going to move on. Thank you, sir, for donating the picture of your shoulder. I like it. So we're going to move on to the case-based part of it. So this is the first case. This is a 54-year-old woman who presents with 4 months of shoulder pain that occurred after her taking her jacket off. She now has trouble getting things off the high shelves and can't put her belt on. So when you ask her these questions, well, was there an acute injury, yes or no? Yeah, so 50% said yes, 50% say no. How many of you put on a jacket at some point today? Yeah, how in God's name do you injure yourself putting on a jacket? It's really hard to do. I'm not the most coordinated person. I got this thing on and I hate wearing coats. I got it on twice today, no injuries. So patients, this is important though. Patients will say, absolutely, there was an acute injury. I remember when that injury happened. Are you losing strength? And she said, no, I can pick things up. It just hurts like crazy. And are you losing range of motion? She says, dear God, yes, I can't get my belt on, let alone a bra, or let alone comb my hair. That's a key factor. So when you start thinking about this differential diagnosis, when you look at these things, was there an acute injury? Not really. Are you losing strength? Not really. So that's much less likely to be a rotator cuff tear, some of these dislocations and fractures. And are you losing range of motion? Well, there's really only a few things that are going to cause the loss of range of motion. Arthritis, frozen shoulder, and if it's a differential between active and passive motion, it's going to be can be a rotator cuff tear. So the easiest thing I can do for a patient with frozen shoulder is just watch them. And I ask them to take off their jacket in front of me. If it takes them 35 minutes and they're moving at 1 mile an hour and they start to sweat, they have frozen shoulder. And we'll get to why, but patients with frozen shoulder, their shoulder literally is stuck down. It is frozen or adhesed, and they cannot raise their shoulder up anymore. So they'll try and they raise their entire glenohumeral joints, okay? Palpation and motion and specific testing in these patients aren't going to be as accurate. So frozen shoulder, adhesive capsulitis is the third most common thing I see. It is almost always non-operative. The real things that I look for in the history and physical is there's no real trauma. So the most common ones I've heard are, I hurt myself taking off a jacket. Again, most people are pretty coordinated, really hard to do, but you probably, if you do really truly hurt yourself taking off a jacket, it's probably an awesome story anyway. Pain all the time. This frozen shoulder hurts all the time. They almost always say the pain is 8, 9, or 10 out of 10. They're usually pretty miserable, and they have limited range of motion. They tend to be going down the range of motion. They'll say, well, last week, I remember because I reached up and I grabbed a cup. This time, I did it, and I got it, but I turned my body 70 degrees to get it. So why does this happen? Well, it's the second most common cause of shoulder pain in patients 40 to 60. We don't know why it happens, and it is associated with diabetes and thyroid problems, and it's one of those things that just has not honestly been studied very well. I told you I was going to give you up-to-date literature. I'm going to give you something from 1976. So I was 2 years old. My dad still had a mustache. But this is the last really good article I could find showing us what are some of the other potential causes of frozen shoulder. And you don't have to read this. This is just more for fun. But what they looked at was looked at the same patients that have problems such as rheumatoid arthritis or ankylosing spondylitis seem to be at higher risk. And it may be a rheumatologic or almost an autoimmune type problem. However, nobody's really studied this for the last I guess I already gave out how old I am. So for the last 37 years. So if any of you are looking for a research interest, this is a very common problem that we don't really study. So if you want to investigate in the lab, this is a great problem to go over. Can I wait till the end of the frozen shoulder section? Thank you. So what happens with frozen shoulder? Now this is a classic orthopedic named process. We have a freezing phase, a frozen phase, and a thawing phase. And in the freezing phase, you're losing range of motion. This tends to take about 6 months. In the frozen point, it hurts a lot, and you have zero motion. And then in the thawing phase, everything tends to get better. Now, this is great. You can tell a patient, well, if you wait 2.5 years, you're going to be all better. And it really is true. If you leave patients alone with frozen shoulder, they all get better. However, I don't like having a cold for more than 20 minutes. So if I tell a patient, that's great, you have frozen shoulder, I'll see you in 3 years, you'll be awesome. It's probably not very good for practice, and it's not really nice for patients. So what is frozen shoulder? This was a good study about 5 years ago where they took biopsies of about 50 patients with frozen shoulder, and they saw the same thing over and over. Arthroscopically, they saw a very reddened and inflamed, thickened capsule, And when they took biopsies, instead of seeing normal capsular structures, they saw all this pink, which is increased collagen and increased inflammatory cells laid down throughout the capsule. And that was very uniform. Rather than an isolated injury of one part of the capsule, the entire capsule looked very similar, and it looked very similar throughout all these patients. So what frozen shoulder essentially is a thickening of the capsule where you get fibrosis or an increase in collagen and thick tissue and inflammatory cells. And if you have inflammatory cells like white blood cells, just like if you get a cut in your hand that hurts when you touch it, it's going to hurt when you push on it. So as your shoulder gets more and more inflamed, it gets tighter and tighter and hurts more and more. You get a gradual loss in range of motion. So how do these patients do? A study 2 years ago now looked at 100 patients, looked at 5-year follow-up and no treatment. And what they found was most patients lasted about 1.6 years. So it's not the original 3 years that we told patients, and almost everybody gets back to full function. That's a great thing to be able to tell your patients is you will be okay. It's just going to take a while. But a year and a half is a long period of time. At that point, you think about what was different a year and a half ago. Alex Smith was still quarterback of the 49ers. Yeah, the Giants were still world champions. So a lot can change in a year and a half, and most patients don't want to wait that long. So anytime we think about what to do for a patient, we can do nothing. Some patients really want just to know what their disease process is. And oftentimes we get to say, hey, you know what, it's okay. You have something, you'll get better. Physical therapy is a mainstay of most orthopedic conditions that don't need surgery. Injections we'll talk about a little bit, and when all else fails, surgery. You do not usually want surgery to be your first choice, okay? As much as I love to operate, I do not want to operate unless I have to. Once we cross that, I've operated on you, things are never quite perfect, okay? So if we do nothing, we kind of know what happens. Somewhere between a year and a half and 3 years, patients get better. Now, I wish I could tell you there's great studies for how physical therapy does alone for frozen shoulder. There's about 10 to 15 studies. There were no really good studies that I felt that were worth bringing to a large lecture that was going to be recorded that says physical therapy really works, and this is a good protocol for it. The reality is physical therapy, if you give it to patients early, meaning in the first 6 months, tends to shorten their time by about 50%. So their time will go down about 9 months. However, every physical therapist has a different protocol, and the protocols are not very standardized through different treatment groups. The reality is I think physical therapy works great because I can't push on their arm every day. Patients don't want to push on their arm. So you really want to find that mean physical therapist and have them be the ones that push on their arm. A significant other that's mad at you works just as well. So what about injections? So injections, when we talk about injections in orthopedic surgery, a vast majority of the time we're talking about a steroid injection, which is a naturally occurring compound in our bodies, but at a much higher dose, which is a very potent anti-inflammatory. It does not make you big, it gives you less inflammation, combined with an anesthetic agent so it doesn't hurt when we inject it. So there's two problems with getting into the shoulder joints. One, it's hard to find. The space that we're looking for is about a triangle that's about 1 centimeter by 2 centimeters. And if you have frozen shoulder, that target hurts a lot because it's inflamed. So this group looked at a randomized trial to look at whether or not patients got better when you did an ultrasound with the injection or done blindly. And I can tell you blindly is not fun for me or the patient. It involves no, no, yes, which is not ideal. So my colleague, Dr. Luke, does ultrasound routinely, and this is what we've seen in our practice. At the time of the injection, it doesn't hurt as much, which is great, and they're more likely to get better after ultrasound injection. So the standard of practice at UCSF for frozen shoulder is to get patients, if they are interested in injection of steroid and lidocaine, or ropivacaine, in an ultrasound-guided manner. So it's more accurate, and it's going to be more predictable that patients get better. So a second study that came out last year looked at, well, how much steroids do you need? They looked at 2 doses. One was a low dose, which is lower than our standard dose, and a higher dose, which was about double what we normally give. And he found that both injection groups got better, and they had no side effects. So from this study, they concluded that you don't need a lot of steroid. You just need a little bit of steroid. So Are steroids safe? How many of you have heard you can only have 3 injections of steroids at some point? Okay. So I heard that all through med school and all through residency, but it was never made clear, is it 3 injections in one body part, 3 injections in 1 year, 3 injections per life? The reality is that's a wives' tale. There's been no study that actually looked at that. What we do know is that steroids are pretty safe in vitro when we give them to cells. In fact, they're pretty inert. They're just really potent anti-inflammatories. And a lot of the studies looked at that we've done at UCSF have looked at combining different anesthetic agents with the steroid. And what we found was that the steroid doesn't kill the cells, but when we combine it with some of the old, very acidic anesthetic agents, it was the anesthetic agent that was causing a lot of problems. So what we've moved to is using anesthetic agents such as ropivacaine or marcaine, which are slower acting and don't kill cells nearly as much, and they're probably significantly safer. So steroids themselves do have side effects. They can cause alterations in blood sugar, but they're not causing the underlying problems that people thought they were. The reality is most people who had steroid injections had them for end-stage arthritis. The horse had left the barn a long time ago. The steroids were just a temporizing measure for people. So thankfully, these are different kinds of steroids. It will not give you a big head and whatever else goes on, okay? So what about surgery for this? I only do surgery for adhesive capsulitis for people who have failed non-operative treatment. So 6 months of doing physical therapy, getting injections, being diligent about doing physical therapy twice a week, for 6 to 8 weeks, and then they repeat that. I've done a lot of shoulder surgery. I've done maybe 5 frozen shoulder surgeries. So this is something that gets better without surgery. If you develop frozen shoulder and your surgeon says, let's get you to the OR quick before you get better, that's not the kind of surgery you want. Okay, so the state of the art for our frozen shoulder, unfortunately, starts 37 years ago. We found out it may be an autoimmune process, but then nobody really picked up that ball and said, should we be treating this differently? In the last few years, we've got great natural history studies that show everyone will get better, and that injections, especially done under ultrasound, are going to be more effective. So second case. So this is a 43-year-old guy, 6 months of shoulder pain. Says it hurts at night. He has pain with overactivity, but doesn't really describe weakness. He's just tired because he hasn't gotten a good night's sleep in 4 to 5 months. He says he can't lift at the gym as well as he did before, but he still goes, and he's still able to do things like elliptical and do some military press. So if you ask him, was there an acute injury? He says, not really. It just sort of came on. I noticed it and wasn't able to do nearly as much. Are you losing strength? Well, sort of. Like I can't use my shoulder as much as I want, but I actually can pick up the same amount. And are you losing range of motion? No. So when we look at this, this is sounding a lot more like a mild rotator cuff problem because there's not really an acute injury. There's not really a loss of strength and no loss of range of motion. So impingement, which is the first phase of a rotator cuff problem, is inflammation around the lining on the top of the rotator cuff, or the bursa. It's very common in middle-aged people. There's usually an insidious onset, which means you don't have that, oh, it was Monday, that was the, I noticed on February 9th, that was when my shoulder started. It's just like, sometime last winter it started bothering me. You get pain with overhead activities, pain at night, and you have difficulty doing some activities of daily living, or ADLs, but not all of them, and you don't really describe weakness. So what is impingement? Above your rotator cuff, in order to slide underneath your acromion, there is a bursa, and a bursa is normally a sac of fluid that allows easy gliding. And as we get older, especially if our rotator cuff gets a little weak from disuse, for those of you that spend a lot of time on the computer, this doesn't necessarily mean we're using our rotator cuffs. So we're seeing more and more of this, especially in middle-aged men in the financial district. So as you raise your shoulder, the bursa on top of your rotator cuff rubs up against the undersurface of the acromion and begins to get inflamed. Over time, that inflammation causes enough pain and discomfort that it wakes you up at night when you're resting and your shoulder hikes up a little bit, or when you raise your shoulder up. So we talked about this, same two dudes. A Hawkins test is pretty good. It's pretty sensitive for impingements. In general, though, it's not very specific. If I push really hard, it's going to hurt no matter what. So what about an MRI? So in general, if my first my guiding principle for whether or not I'm going to get an MRI is it going to change management, or is it going to change whether or not I'm going to take somebody to surgery, whether or not I'm going to prescribe something different, or is it going to change the surgical procedure I'm going to do? In general, people don't have weaknesses, and this is the first time they've seen me. I'm not going to need to get an MRI. However, MRIs are pretty good, and if I suspect a full thickness tear, I'm going to probably get it because a full thickness tear is different than inflammation or partial tears. Now, MRIs get a lot of bad press. They get a lot of good press because everybody wants an MRI. I would warn you, MRIs only tell you what's degenerating in your body. So unless you really want to be depressed for a day, don't get an MRI just to see what's going on. MRIs will always show something. A radiologist is looking for everything, and they are an objective reader of that report. They will almost always find something. Whether or not that's clinically relevant is an entirely different story. We should be using it to augment diagnosis, not make it. And more importantly, are what the patient tells me and what their physical exams are. The MRI should back this up. Beware, anytime in the New York Times or New England Journal of Medicine there's an orthopedic issue, it's almost always negative. So suffice to say, he was sad after his orthopedic surgery. Okay, so we kind of covered that. So the difference between a partial thickness tear and a full thickness tear is a huge difference. How many of you are over the age of 50? You all have at least some partial thickness tears in one arm. It doesn't matter. It's just like saying you have a little bit of male pattern baldness or whatever women have that's just isn't sad. A partial thickness tear just means your rotator cuff is degenerating. The problem is when the radiologist reads that, he or she will always find something that looks not quite perfect. They'll call it tendinosis or partial tearing of the rotator cuff. That sounds horrible. I don't want anything in my body torn, let alone something as cool as my rotator cuff. But if you look at the difference, this is your rotator cuff muscle coming over. This tendon, the black structure, comes and attaches all the way over there. This was read as a high-grade partial tear. This person had no shoulder pain. This person is a little bit different. Rotator cuff muscle comes over. The tendon stops here. It's not even attached here. This looks drastically different than this, but the patients had the same complaint coming in as my report says that I have a rotator cuff tear. So you want to use the MRI to look for serious things, not necessarily to rule out things. So how do we treat impingement? Well, we rest, we avoid offending activities, which means if patients say CrossFit hurts, the answer is no CrossFit for 6 weeks, and they get better. Usually physical therapy for 6 to 12 weeks. If you strengthen your rotator cuff, instead of your shoulder riding up, it'll start pulling down again when you raise your arm up. Extremely effective. Active and passive range of motion if you have any problems. Strengthening the muscles in the back. How many of you guys are guys? Raise your hand. So guys love exercising every body part they can see and hate doing everything in the back. So we send them to the gym and say, get 2 mirrors and then you can see your back. And then they'll do their periscapular exercises. Anti-inflammatories. In some cases, I'll do a steroid injection. And if all else fails, we'll do surgery. So in general, my dividing line is if patients say, oh, I have night pain, but I sleep through the night, I'm going to predominantly do physical therapy and anti-inflammatories because a vast number of patients are going to get better. If they have pain with activity and it's waking them up, I'm going to try to have them consider doing an injection because those people tend to have more inflammation. And like I said, that injection really decreases inflammation. Overall, we rarely do surgery on patients with isolated impingement. And why is that? Well, first, this is Bill Levine, who's one of our colleagues in Columbia. He looked at, well, what are people doing in the United States? And what he found was, as we got better at arthroscopic surgery, we quadrupled the number of subacromial decompressions for impingement. That's not more people getting it that have that disease process. It's that we got better at doing it and it became an easier procedure, so there was a lower threshold. The reality is still most people get better with non-operative management. What is also scary is that our younger people who are just passing our boards in the same period of time, we're doing a lot more of these, suggesting that one, great, we're good at doing them, but the drawback is because we're good at doing them, our threshold to bringing everybody to the OR went down significantly during that time. That's only a 10-year period of time. So how do these patients do? Well, if you don't operate on people with impingement, you look at 100 consecutive patients, in 2 years, their average shoulder score on a scale of 0 to 100 went from not so good, they got an F, to an A. I'd be pretty happy. But if you ask them, 30% still had a little bit of twinge of pain they rated between a 0.5 and a 1. So these authors, because they're biased and they're shoulder surgeons, said, well, we should still operate on it, even though that pain was a 1 out of 10 occasionally. If we do have to operate on patients, 93% will have good to excellent results. So the bottom line for impingement for me is I will try to get patients better non-operatively, because a vast majority of them will get better from in a non-operative standpoint. But if they do need surgery, I can tell them with a clear conscience, look, 9 out of 10 of you are going to do really well. All right, so we're going to make it a little bit more complicated. So this is a 56-year-old person. He has 3 months of shoulder pain and weakness after an awkward fall while he was hiking. He hasn't been able to get to the gym, and he has pain at night, and lifting things up is physically difficult. So when you ask him, well, was there an acute injury? Well, this time there was. He does say he's losing strength, and he doesn't really lose range of motion. So that makes you much more worried about a rotator cuff tear. Now, I talked about impingement. Impingement is inflammation around the rotator cuff. So this impingement looks like cotton candy stuck on top of your rotator cuff. And once we suck it off, your rotator cuff looks really healthy. You can have partial tears, but they're relatively common and usually pretty benign. And a certain subgroup of patients will get full thickness tears. Now, how much of that, how common is that? Well, it depends on how old you are, and we'll get to that. So what is a rotator cuff tear? Well, we remember that a rotator cuff is a sleeve of muscles that goes around your shoulder. It is a very common condition as we get older. Our rotator cuffs were meant to last 59 years, just like we did in the 1800s. Unfortunately, we have gotten older. So 40% of patients over 60 will have a tear. So half of you should be like looking up my office phone number right now. As we have an older population, this is great. You guys all want to stay active. My parents want to stay active. But they are still going to be at the same risk as if they weren't active or if they were passing away at 59. So we want to keep people active, but it's going to be more and more of a challenge as we get people living to 60, 70, 80, 90, 100 and still trying to do the things that they want to do. So simply put, your rotator cuff tear is a loss of attachment of the rotator cuff tendon to the bone. There is now a complete hole that I can stick my finger through. It is either traumatic, you fall down, or you go skiing this weekend, or without trauma. And they can be, the without trauma are the ones that are, I didn't really notice an incident, and I got an MRI, and my doctor says I had a rotator cuff tear, but I'm actually doing pretty well. Usually, but not always, they can be asymptomatic and can cause shoulder pain and weakness. You can imagine if you have a tiny 2 millimeter full thickness rotator cuff tear and 7 centimeters of healthy rotator cuff tear, you're probably still going to be okay. So we've learned a lot about rotator cuffs, and I think one of the things I really like most about shoulder surgery is we've learned a ton about rotator cuff tears in the 6-7 years I've been training. So we have much better recognition of the diagnosis of rotator cuff tears. We know that MRIs are pretty good, but there are still limitations, and this is one of the reasons I don't love getting an MRI. So when I get an MRI for a supraspinatus tear, the rotator cuff tear on the top of the shoulder, it's really, really good. It's 95% accurate. It's pretty easy. I can not only tell exactly what kind of tear it is, but I can predict what I'm going to have to do in surgery, which is exactly what I want from an imaging study. I knew this was going to be a long, narrow tear, and if I put sutures from side to side, I'd be able to close that hole up and then put an anchor down here and tack everything back down. However, we talked a little bit about the rotator cuff in the front, your subscapularis. Well, this is much harder to image because the attachment is intrinsically different. It's longer and broader, and it occurs at a more of a flat angle in the front of the shoulder rather than a nice rounded angle. So this group out of Texas looked at 40 patients who they had an arthroscopic evidence. So during surgery, they said, wow, there's a subscapularis tear. It's off the bone. And they looked back and realized that only about 60% of the MRIs were read as negative. So MRIs are not a very good diagnostic tool for a subscapularis tear. A physical exam is actually a better diagnostic tool than an MRI. So one of our residents wanted to look and see how important these tears were. So what he did was he looked at 101 of our previous patients and looked and found that 8 of them had undergone previous surgery and had a misdiagnosis. Most of them had had a few surgeries. And when we did a specific MRI and looked very closely at the subscapularis, we found that most of them had missed a subscapularis tear. So what this means is that if you have continued shoulder pain after either a standard rotator cuff repair, after an impingement type surgery, this might be one of the reasons. And as a group, we do a lot of them here because we feel that a lot of people have anterior shoulder pain are ending up with subscapularis tears that are not well diagnosed on MRI. So in people that you talk to say, yeah, you know, I'm really a little bit weak. The front of my shoulder is bothering me. You really want to think, gosh, could this be a subscapularis tear? And if they're weak, lifting off on their back like this, have them go see a doctor, preferably a shoulder surgeon. So the other thing that we've gotten really good at is we've gotten good at understanding biomechanics. And the great thing about orthopedics is it's cyclical. So in the 1980s, you can think about everything that was different in the 1980s, we did an open repair. We made a big open incision, and we took a long time. A rotator cuff surgery in the 80s was a 5-hour ordeal. And we really tried to restore the footprint. We wanted that entire rotator cuff to get down and re-establish the normal anatomy of the rotator cuff. Well, in the 90s, we started doing rotator cuff repairs arthroscopically, which was great. We didn't make a big incision. We did little poke holes, but it was kind of I don't want to say we freaked out, but we went in and tried to do it as quickly as possible, because if we did it too slowly, the shoulder got inflated with fluid. We couldn't see what we were doing. So we would do a single row. We would spot weld that rotator cuff as best as we could. It worked okay, but it didn't work all that well. And we decided to get a little bit tricky in the 2000s. We said, well, if one row is better, orthopedic knowledge suggests 2 rows is more better. So we did double row, but you can imagine if you've got anchors in, there's sutures coming out of each anchor, there's 4 out of each anchor, and we do 8. That's 16 strings standing in front of you, and it became a very daunting process. So we went back to a very there's a very elegant gentleman named Dr. Elatrosh, who went and reestablished how to do a reestablishment of the footprint arthroscopically. And since that time, in 2010 to 2013, I think our repairs have gotten a lot better. So this is an example of a double row, and you can see if we put an anchor here, pull sutures through, we spot weld the rotator cuff in 4 different places. That looks pretty good, and in many, many cases, that's totally okay. But if you look at the difference between what's called a transosseous equivalent, or reestablishing the footprint, put anchors here, pull sutures down, and put them through these anchors over here, we really are pushing down in a much better fashion, very similar to what we were doing in the 80s. But we can do this arthroscopically in under an hour. So this gives us a much better anatomic footprint. It's a much stronger repair, and it has a better load to failure, which means we can get patients moving a little bit faster. And if patients move a little bit sooner than we tell them to, it's probably a safer repair. So we know from recent studies, when we look at systematic reviews or look at large volumes of papers put together, our healing rates when we do a single row is about 80 to 90%. Our healing rates with a double row is about 80 to 90%. Now, why are they the same if this is better? Well, because most of us are doing a double row repair for bigger tears. So the bigger tears are going to be harder to fix, have a higher failure rate, so we're using a more complicated repair construct. No matter what, our outcomes still are dependent on how big the tear is going in and how good your muscle is that's actually the motor to your shoulder, which we'll get to in a second. Now, I'm a big believer that I can teach anybody to do rotator cuff surgery. It's not that hard. I can teach people in the laundry room. That's our laundry room. That's a 6-year-old, and she's completed her first rotator cuff repair in about 15 minutes. So one of our residents looked at this and said, well, are we doing more arthroscopic repairs? And absolutely, we've gotten much, much better at doing arthroscopic repairs. About 75% of our rotator cuff surgeries are done arthroscopically. And why is that important? Patients do better for the most part, unless it's a really, really big tear. They are outpatient procedures, which means they are less expensive. There's less of a burden to society, and it doesn't take down the deltoid. So the pain afterwards is much, much better. It's a much better surgery. The problem is our young sports-trained doctors don't know how to do open surgeries anymore, and there is a subset of patients, people who have had 2 failed rotator cuff repairs, who have had massive rotator cuff tears, who probably still need that big open surgery to maximize the chances of success. So clinically, we know that if we do more anchors, especially in a transosseous equivalent, it's probably better. We don't have great data, but certainly for bigger tears, it's probably the best thing to do. This group has looked at systematic reviews every 6 months for the last 3 years, and they write almost the exact same paper. But what they find is that bigger tears need more anchors. It's great. That's what I love about ortho. It just makes intuitive sense. So it's important we also understand the natural history of rotator cuff tears, not from a tendon to bone healing problem, but also what about the muscle? And this is, I'm going to try not to spend too much time being nerdy, but it is important that we consider the muscle that's driving the tendon to bone attachment as well. So Ken Yamaguchi, who's a shoulder surgeon in St. Louis, has done a long series of elegant tests that sadly show us that at least people in St. Louis have a lot of rotator cuff tears. So what he did in 2006 was he looked at patients with symptomatic rotator cuff tears and then looked on the other side to see if they had rotator cuff tears. Great, easy study. Nobody had pain over there. Well, it turns out 40% of them had a rotator cuff tear on the other side, a full thickness tear. So these can be there without you even really knowing. Now, over the next 2 years, half of those patients became symptomatic, and 40% so 90% of these patients, the tear got bigger. So what does that mean? It means that you can have an asymptomatic tear, but when it gets to a certain size, you're going to know it. So it doesn't mean, oh my goodness, go run and get an MRI tomorrow. It means if your shoulder starts bothering you, you should probably get it checked out. It doesn't necessarily mean everything's okay. So a similar study, which I thought was a really elegant study, was done in London, Ontario, looked at risk factors for progression. And what they found was that very rarely did tears, this was about 200 patients, very rarely did tears get smaller, and they never totally healed. A lot of them over a course of 2 years didn't get any bigger, but about 50% over those 2 years did get bigger. Now, who are these people that are going to have the bigger tears? They're going to have, or progression, they're a little bit older, tissue's not quite as good. They have a larger tear to begin with. Once you have a certain size tear, it's kind of like when you tear a piece of clothing a little tear, you're okay. I've had a hole in this shirt for like 3 years, it's okay. I had another shirt that tore here and it was about this big, and by the end of the day, it was a really embarrassing clinic. And then when their muscle gets what's called fatty infiltration, or instead of having muscle inside the muscle, you have fat inside the muscle, this is a poor prognostic factor, and it suggests that your tear is progressing. So what about the muscle? So you think about your rotator cuff, and we talked about this at the start. It's muscle that attaches to tendon to bone. Well, if you don't have a strong muscle, it doesn't matter how good that tendon attachment is. So if you look closely at this patient, he is missing most of his infraspinatus. This is a big hollow area where his infraspinatus should be. And this group out of Switzerland looked at a huge group of patients and found that these muscle changes usually happen if you left rotator cuff tears alone for 4 years. So this is they get pretty much every rotator cuff tear in the Western Europe, and they found if the patients waited a long period of time, this muscle, instead of being healthy, normal rotator cuff muscle, was small and was infiltrated with fat. And they found that, not surprisingly, older patients and the amount of how small the muscle was, amount of atrophy, correlated to how much that fatty infiltration progressed. And this is just an example. Normally, you want your muscle to look nice and dark. If you look at this rotator cuff muscle on the top, it's really tiny. It usually fills up this whole section here, and inside it doesn't look too healthy either. It's got these white dots, which are fat inside. So we know that fatty infiltration, the abnormal process of muscle degenerating in the rotator cuff, is associated with as we get older. And we also know that even in the setting of an okay infraspinatus, rotator cuff in the back, if you have a big enough tear in the rotator cuff in the top, the supraspinatus, that muscle can develop fatty infiltration. So my rationale for most patients with rotator cuff tears is I want to see you before any of these things happen. So when I think about these things, this is what most of what our lab goes through, and I'm going to go through this relatively quickly because it puts my wife to sleep like that. Most people focus on tendon degeneration and why we can't get the tendon to heal the bone. Our lab focuses on muscle degeneration, how the muscle gets smaller, undergoes atrophy, and goes and has this fatty infiltration. The amazing thing about fatty infiltration is it only happens in the rotator cuff to this degree. So it's biologically unique to the rotator cuff. So what we did, this is not anything you should read, this is immediate bedtime material, is we looked at specific pathways and found that if we can alter certain pathways that normally regulate atrophy, we not only can decrease the amount of atrophy in the rotator cuff, but we can block the progression of fatty infiltration, which is great because if I know somebody who has a rotator cuff tear, and I can change their pathophysiology by changing some of the molecular signaling in their muscle, I can improve their outcomes after surgery. So what about those patients who don't want surgery though? How do they do? So typically, if a patient comes in and says, oh, I've got a rotator cuff tear, it doesn't bother me, what we do is we give them rest, activity modification, which means if it really hurts, don't do it. Again, no CrossFit. Anti-inflammatories, physical therapy, and sometimes an injection. We don't have really good evidence until recently on how those patients do. So my colleague, Dr. Ma, who worked with a large group of shoulder surgeons and looked at the effectiveness of physical therapy in patients who decided they did not want surgery. So this is not a randomized study. There is some bias. If you come in and say, I don't want surgery, you're already leaning down the non-surgery pathway, which is great, but there is some inherent bias. But what they found was that in general, if you look at how patients did, they were already, most of them were doing pretty well at 6 weeks and a lot better at 12 weeks. So if you look at their ASES score, which is a score of how your shoulder is doing, it goes from 54 to 83 at 12 weeks. So many patients, if they have small rotator cuff tears and decide they don't want surgery, do okay. And with those patients, I say, absolutely, let's try physical therapy. Let's try to get you better. If you don't get better, we can always operate on you later. Most people who decided they didn't want surgery, so 85% went 1 year, no surgery, did great. The 15% knew right away. So most of those people had surgery within the first 12 weeks. So you're going to know right away whether or not physical therapy will help you. So for full thickness rotator cuff tears, my rationale is small tears do better. We know that from all of our literature. We know that patients are less symptomatic, they're stronger, their muscle is better, they have lower rates of going back to the operating room because they retour, and most importantly, it's easier for me. And I don't like hard surgery, I like easy surgery. So if I see a patient with a symptomatic rotator cuff tear, if they don't want surgery, that's great. I will try to get them better with non-operative management. But if they're persistently weak, persistently waking up at night, I would rather treat a small tear because there's a much better chance that they're going to do better than wait till the patient gets a really, really big tear. So if a patient has a full thickness tear, I don't let them leave my clinic. They're my friend for life because I want to at least examine them once a year to make sure that their symptoms are doing okay. So in the future, what we're going to need to do is improve tendon to bone healing. If you think about how many of you guys have heard about stem cells? Yeah, pretty much everyone. How many times do we actually use stem cells in orthopedics? Pretty much never, because we don't know how to deliver stem cells and growth factors in a time delivery. Stem cells and growth factors in one big shot tend not to work. And my goal is to improve muscle biology after rotator cuff repair. All right, so last thing, we'll go through this quickly because I know you guys are probably tired of shoulder and me. So this is a 75-year-old person, and he has a 5-year history of gradually progressing pain. He doesn't have weakness, but he can't lift his arm above his head. It just kind of raises up like this. He has a history of arthritis and his hips and knees, and says this feels pretty similar. So what's the most likely diagnosis? Yeah, I love asking patients if they've had a rotator cuff tear on one side. Does this side feel the same? They're like, yeah, okay, good. You know, patients are your best friends because they can usually tell you the diagnosis. So what is arthritis? So normally, cartilage is ridiculously smooth. It is smoother than taking a piece of ice from the speed skating on the Winter Olympics and sliding it over another piece of ice. It's 1 order of magnitude smoother than that when you take 2 pieces of cartilage. So it's very, very smooth. This is your humeral head, and this is your glenoid. Very, very smooth cartilage. Arthritis is the destruction of this cartilage. You no longer have that smooth surface. So why is that smooth surface important? Well, in our joints, you have this very nice, healthy cartilage. There's no nerve endings in it, which thank goodness, because otherwise you'd feel every movement. It's distracting enough that I feel this suit on me. I don't want to feel my joints moving back and forth. And there's very few cells, because if you have a lot of cells, you're not going to have the important mechanical properties that are going to allow you to walk and run and jump and throw billions of times. So you need a very robust acellular structure. But the problem is if there's no nerve endings, you don't sense early damage. You don't know when you have early arthritis. It's the opposite of your fingers. If I put my hand near something hot, I know right away. If I had cartilage on my end of the finger, I could probably put it on the flame and wait 5 minutes before my cartilage would know. And because there's very few cells in cartilage, you can't regenerate. So if nothing else, if somebody tells you they have osteoarthritis or arthritis, I want you to memorize that. So this is normal cartilage, and as we go down the stages of worse and worse arthritis, we get little fissures, progressive loss of cartilage, and then little bits of cartilage all the way down to the bone underneath that. Now, what does this look like clinically? Sometimes you can have local cartilage injuries in the shoulder. More often when you have arthritis, you've lost all the cartilage. The reason why this hurts is the bone right underneath the cartilage has a lot of nerve endings. It senses, if you ever jumped really hard and your knee hurt for a few days afterwards, that's because you probably got a bruise right underneath the cartilage where it senses mechanical load in a very different way. That's your first early warning system, which unfortunately is usually too late. So diagnosis of arthritis, patients will describe this as a toothache, all the time pain. They will have limited range of motion. They have bone spurs, and they have bone grinding against bone. Everything they do hurts, okay? On x-rays, this is a normal x-ray, and then this is a shoulder with a loss of joint space. You have bone rubbing against bone, no more cartilage there. You get a little bone spur. Well, why do you get bone spurs with arthritis? It's because your bone sees mechanical load as an impetus to make more bone. So your bone's way of saying, gosh, I have less cartilage. I need less force on me. I'm going to make more bones. I'm going to make a bone spur. Horrible idea. It should just make more cartilage, right? If we made more cartilage, I wouldn't have to do shoulder replacements. However, instead, we make bone spurs. So do you need an MRI? Probably not. It's only useful if you also suspect a rotator cuff tear, or in some cases for surgical planning, it helps with the anatomy of the glenoid. So the only proven treatment for shoulder arthritis is to do a shoulder replacement. Anti-inflammatories, physical therapy, they are all temporizing measures. They don't put cartilage back. Are they worth trying? Absolutely. Are they worth trying for younger people? 100%. But the only thing that's been proven to have a long-term benefit is a shoulder replacement. So this is the original shoulder replacement. It was done in the 1880s. It was a leather ball and a leather shaft. Believe it or not, a lot of these got infected. Didn't work very well. Pretty cool, though, all things considered. I mean, it looks relatively similar to what we do now. This is pre-antibiotic. So the fact that even one of them, somebody said, yeah, sure, go ahead, put that leather thing in me, close me up, not a big deal, is pretty amazing. So now what we do, and we do a shoulder replacement, it really is a replacement of the ball and socket. We put a metal ball attached to a shaft that goes in the humerus and a plastic socket. Now these work really well. This is a recent study that came out last month, and they looked at total shoulder replacements for 15 to 20 years. And what they found was patients did really, really well for about 15 years, and then they started dropping off between 15 and 20. But if you look at these bars, there's a big standard deviation. So lots of patients are really doing pretty well, 15 to 20 years after their shoulder replacement. That's better than hip and knee replacement, but don't tell the hip and knee doctors that. Our failure rates, not surprisingly, as we get further and further out, increase. So at 20 years out, about 75% of patients still have their shoulder in, but that means 25% have had to have a revision procedure. Overall, that's a great success. And so for standard shoulder arthritis, that's fantastic. So what about if you don't have a rotator cuff? So this is somebody, they've worn out the ball and socket, but they're rubbing up against here, got an MRI, and I see rotator cuff muscle here. I don't see anything that even resembles a tendon over there. So this is a big problem, right? So if I do a shoulder replacement in this setting, I put my socket down here and my ball up here, what do you think is going to happen to that ball and socket? Yeah, it wears out on an average of 4.5 years. So this is an example of somebody with a huge rotator cuff tear. This is looking from the side, remnant of biceps tendon. Anytime I can look all through the shoulder and I don't see any rotator cuff to speak of, that is a problem that's not going to be able to be solved with a simple problem. So what we've done in the last 10 years is we've developed strategies to fix what we call cuff tear arthropathy, or people with arthritis in the setting of a rotator cuff tear. And we do that by something that's a little bit ridiculous. We do what's called a reverse shoulder arthroplasty. We take the ball and put it on the socket side, and we put the socket and put it on the ball side. I don't think that's that much different than looking at that original picture of leather and saying, and I tell patients, so I'm going to put a ball on your socket and your socket on the ball side. It's called a reverse, but your shoulder will be fine. They go, okay, that's fine. The reality is this actually works pretty darn well. Well, how well? Well, it was started by the French in the 1990s. If you want to do radical, innovative surgery, go to France, because the French will let you do anything to them. However, a lot of them failed, similar to hip replacements early, knee replacements early. 25% failure rate at 5 years, and 80% had what we called scapular notching, where you were basically rubbing into the scapula right here. And they had a lot of catastrophic failures, meaning it didn't just fail, it failed spectacularly. They couldn't have another surgery. So one of the French guys who did a lot of them said overall they did pretty well, but at 6 years they started to deteriorate. And he really said this should be reserved for only the patients that absolutely need it. Well, in the last 10 years, even though we've seen a fair number of complications, this is somebody with a lot of notching. You see they've got a big divot out here. They can get infected, which is a big problem. Or they can show up like this in clinic, a gift from Chico, and say, can you please fix this? We know that reverse shoulder patients actually do really well, and it's the final common pathway for when nothing else works in the shoulder. And because we're a tertiary referral center, we do a lot of these shoulder cases here. So Dr. Ma and I have done about 225 patients now. Overall, we take patients that are not functioning very well. They have a score of, on a scale of 0 to 100 of about 40, and we get them up to about 75 to 80. We have relatively few complications, a lot less than the original diagnoses suggested. Their range of motion is pretty good. Their forward flexion, meaning they can come forward to about 120 degrees, it's not great. Right now I'm at 180, but 120 gets me to be able to reach something off a shelf. What they cannot do is they cannot turn their shoulder out, because the reverse will allow you to use your deltoid to raise up like this, but it does not get this motion back. So you have to tell patients, you're going to comb your hair like this. You're not going to be doing your long flowing hair like that, okay? We also looked at whether or not the implant we use is important in lowering some of the complications. And what we found was that if we put the base plate right where it belongs, all the way at the bottom, our incidence of non-significant or very mild notching is about 80%. So what we took home from that study is if we put the reverse in the right position, we're more likely to have a good outcome, more likely to have our patients do well. So in general, reverse shoulder arthroplasty is a good solution to a complicated problem, but we don't have 15, 20, 25-year data because it's only been available in the United States since 2006. Early complications do occur, and they're a disaster when they occur. So most people would recommend that if you're going to see somebody for a shoulder replacement, or especially a reverse, you want to ask your surgeon, do you do a lot of them? Just like a knee replacement or hip replacement, you want somebody that's an expert, because it's going to be less likely that they're going to put the components in the wrong spots. So that's it for shoulder. I'm happy to take questions. Yes. Sure. So what are anchors? So anchors are they are things that we place into bone with sutures that come out that we can then attach to other structures. So they're either made out of metal, and they're about 5 millimeters, or they're made out of plastic, which are about 2 to 3 millimeters. How many rotator cuff surgeries do I perform? Depends on the month, but anywhere between 10 and 20. So why do small tears not necessarily become symptomatic? Your rotator cuff, like we talked about, is a big sleeve of tissues. It goes from the front of your shoulder all the way to the back. If you have a 5 millimeter hole, it'll be fine. It's just like, I'm a little bit bald right here. You can't tell. It's okay. There's enough coverage here that it allows the rest of my head to do everything I want. Yeah, so once you get more than about a 2 centimeter width of tear, that's when you start losing the ability to compensate, because that's when the force of your deltoid is stronger than the force of your rotator cuff, and you lose that force couple. Yes. We didn't talk much about biceps. The question is, do biceps tears go along with rotator cuff tears? And the answer is yes, absolutely. Your biceps runs right in between your supraspinatus and your subscapularis. It runs right in between, so it's susceptible both if you have a supraspinatus tear or a subscapularis tear. The treatment is controversial. We don't have great data one way or another. You asked, well, why do we sometimes cut it when you get to a certain age? Your long head of your biceps is only important for what we call supination, or turning your palm up like this. And if you want to prove that, take your arm, put it like this, and then turn your hand up and feel your biceps. Your biceps actually flexes more turning your hand up like this than doing a biceps curl. So if you want to hint at the gym, when you go, don't just do this because you look silly, but start and rotate your hand out and then bring your arm up, and that's a better biceps exercise. Doing curls, like how most people do, where you're only going from here to here, doesn't do much for your biceps. So why cut it? The reality is most people don't use their biceps too much. Most of the time, however, if we're going to cut it, we'll do one of two things. We'll cut it and then fix it down here, which is called a tenodesis, outside of that groove, so it still functions like a biceps. Or we'll just cut it and let it go. In older patients that have low demands, there's less likely a chance that they're going to have pain with just cutting it and letting it go. Younger people who still do a lot of work with their hands, you should probably cut it and fix it, because they're less likely to have symptoms like cramping. Right, so most natural history studies show that after your tear increases in size over 2 centimeters, you start to become symptomatic. So usually, it's pretty rare for me to have a patient that is totally surprised that they have a chronic massive rotator cuff tear. They usually know something's been wrong for a while, especially if you ask them pointed questions like, when was the last time you really lifted your arm above your head? So most of the time, asymptomatic rotator cuff tears, if they're truly asymptomatic, those patients will know when they've progressed, because they'll come back and say, now something feels different. Yes, that's correct. Any small, it's very rare for a full thickness tear to heal itself. Correct. So you will get tendon to bone healing, but it is not as good as your original, what you were born with. So, yeah, so that's a great question. So patients like you that more likely had more impingement or partial fraying of your rotator cuff, some people are more susceptible to that. So people who do a desk job, or who are, what I would say are kinematically challenged at the gym. So the people that you look at and take videos secretly and send it to your friends and go, dear God, look at what they're wearing and doing. There can be things that you're doing in your daily life that are making you more susceptible to it. But what we do know is that people who exercise their shoulders less are more likely to have shoulder problems. So you need a certain amount of resting tone and function and coordination in your shoulders. So for you, that just means keep exercising. Sure. So what can somebody do who hasn't had shoulder problems to keep from seeing me? In general, doing exercises for your periscapular muscles, so the muscles behind your shoulders, the ones like the upright rows where you come and squeeze your shoulder blades back, taking breaks while you type, so you don't type for hours and hours on end, because you end up just, your shoulders feel horrible, and giving yourself breaks from doing everything. And that includes when you get into an exercise program. If you exercise the same exercise for 8 weeks straight, you got to give your body a little bit of a rest. So it depends. So in our study, what we found was that there was a small but significant percentage of people that had had a rotator cuff repair on the main rotator cuff, the supraspinatus. When they came, they had persistent pain, and they either had a missed subscapularis tear, or they had now retorn, because we think that once you've torn one, you're biomechanically at a disadvantage for your other tendons. They're taking up too much other stress. I said we know which pathways. The reality is we know which pathways are important in animal models. We're not quite at where we can test it in people. So right now, the most potent drug that we can give to inhibit fatty infiltration, which works about 100% of the time in rats, is a potent anti-rejection drug called rapamycin. So it works great, but nobody really wants to be on the same thing you get after a liver transplant. So we're looking for more specific things. This time next year, I will have a great over-the-counter treatment, but I can't divulge that yet. So multiple family members with shoulder dislocations. Were they traumatic or atraumatic the first time?
Traumatic.
Truly traumatic, like you fell down and dislocated?
Or threw something badly.
Okay. So there's two classes of shoulder dislocators. They're called TUBS, T-U-B-S, or ambry. Totally makes no sense. So TUBS is traumatic, unilateral, means it only happens on one side. You have a pathologic lesion called a Bankart lesion, or B for Bankart, where you've torn the labrum off the capsule, or off the glenoid, and that usually requires surgery. It does not often get better on its own, especially if it's happened over and over. Throwing or doing things awkwardly usually falls into the other category, especially if there's a hereditary component. That's ambry, which means atraumatic or less traumatic, multi-directional, which means you can dislocate. Some people say, I kind of feel like my shoulder's loose all over the place. And the treatment for that is it's bilateral, so B, and then rehab. And it's getting your rotator cuff muscles, the dynamic stabilizer of your shoulder joint, to be as strong as possible. So that's a great question. Why is the pain with rotator cuff problems most frequently felt at night? We don't have a great answer for that. We suspect is because when you lie on your shoulder raises up a little bit, so you're shrinking that space where that inflamed bursa is. And so that's one good biomechanical reason. The other thing is everything hurts at night. It's quiet, it's dark, you've turned off the Olympics. There's nothing to think about but why does my shoulder hurt? So it's probably a combination of both. Whoa, does bicycling bother the shoulder? It can bother your biceps. The most common thing it bothers is if you ride in San Francisco, the Muni tracks are exactly designed to stick your tire, so always cross at right angles or I will see you with a clavicle fracture. So that in and of itself is the most common problem. So, all right, thanks.